my personal experience with ripretinib, I've been fortunate to be able to participate in the phase 1 study, in particular the dose expansion part, where the dose was known and we were trying to check and see what is the activity that we're seeing. I participated in the phase 3 Invictus trial, and currently am also participating in the phase 3 trial that is evaluating ripretinib versus sunitinib, and the results of which are not known because the study is not yet finished. But what I would say in that experience is that I think in general, as I've said, while I've listed and talked about side effects that the drug can have, I think most patients tolerate it very well. I have some patients who are continuing on the drug for more than 2 years and have been able to tolerate that without major side effects that is limiting their ability to do what they want to do. It's been gratifying to see patients whose disease has been controlled, and even patients whose tumors have decreased in size. Certainly from the Invictus data and in the phase 1, the number of patients whose tumors shrink is less than 10%, but that is on a par with what we see with Sutent and regorafenib. So I think it's sort of in that same ballpark. I think in terms of tolerability, in general, it is well tolerated, on a par with or better than the things that we think about in second and third line therapy. I think for just patients, the real medicine or the real art of medicine for these patients is working with them to make a dose of therapy of a drug work for them. And certainly studies look at using X dose of a drug in a certain way, but over with time and experience, I think learning how to start a drug, titrate it up to where a patient can tolerate it is very important. In my experience with ripretinib, there's less of that needs to be done. Patients really can tolerate 150 milligrams for the most part, and then if they need to because their disease has progressed, then can tolerate 150 milligrams twice a day. So I think it's been, from my perspective, a very easy drug to use, and I think patients have found it to be very tolerable, with the one caveat of this hair thing, which is quite different from many of the other drugs that they're on. So in the patient in the case, ripretinib was used as the 4th line drug, and now that is available based on the FDA approval in May of 2020. I think that that's a very appropriate use of this drug, and I would expect that this will likely be what many physicians will choose for their patients. Avapritinib, as we know, was also recently approved, although the indication for its approval was much more narrow for patients with the D842V PDGFRA mutation. Interestingly enough, the drug, when it was developed in the phase 1, not only was tested in patients with that specific mutation, but also in patients with KIT mutations. And there are some patients who benefit. We know that this drug was tested, and there was a recent release in the press of the study comparing it to regorafenib, where the endpoint that was being evaluated was progression-free survival, to see if avapritinib would be better than regorafenib. And based on the press release, that was found not to be the case. We haven't seen that data, so it's a little bit hard to comment on what does this study mean and what are the implications. But in my mind, based on data from the phase 1 study, which I participated in as well as in the phase 3 trial, I have seen some activity of that drug, and so I would think that that is a drug you may be able to utilize in this group of patients. The toxicities are similar to the kinases with one exception. It does seem to have some uh, toxicities of special interest having to do with cognition, memory, which I think have to be managed and handled carefully in patients. But I think that is, ripretinib is a drug that may have a role for selected patients whose disease is progressing beyond the standard therapies that have been approved for KIT mutant GIST.